I'm Dr. Kristofiak. Everyone just says Dr. K. I'm the medical director of sports medicine here, as well as the medical director for the MORAHAN Center. I'm also an assistant team physician for Rutgers Athletics and do medical school education. A little bit about the MORAHAN Center. The MJA Center, we have over 33 sport contracts. We've done over 40,000 cardiac and concussion screenings since 2010, educated of almost 20,000 in athletes, professionals, family members, etc., on concussions and cardiac screenings. And we have several publications. Most recently, have been acknowledged at the at a more international level. This event is a CEU event for athletic trainers. It's worth one CEU, and we can give you some more information about making sure you guys get those credits if you stay on for the entire time. Today, Diana Toto is going to be talking about advances in sport-related concussion, a new chapter. Diana and I work very close together, kind of like peas in a pod in sports medicine, and I'm really happy to work side by side with her on sports medicine. She's our director of sports medicine and business development at Cooperman Barnabas Medical Center. She's also administrative director of the Matthew J. Morahan Center. She has served as a program director since 2011. She started early. She attained her bachelor's degree in kinesiology at Penn State University. And since I got my degree at Rutgers University, we have some Big Ten competition going on with that. But then she moved on and she got her master's degree in clinical exercise science from East Stroudsburg University. Prior to joining Robert Wood Johnson Barnabas Health, she worked as an exercise physiologist with athletes and other special populations for 7 years in the healthcare industry. Of note, just to share this, because it's extremely relevant to the topic she's presenting on today, she's our lead author on a MORAHAN CAARP manuscript and algorithm. It's a trademark algorithm that we actually use for our concussion-based care. She was actually invited to present at the Amsterdam International Conference on Concussion that's going to be held in Amsterdam this year. So our team is really proud of the research that we're getting published at the international conference, and very proud to be able to introduce Diane today. She has a great topic prepared for you guys. So again, enjoy, stay on for the entire time. We'll make sure we get you those CEU credits, and there's going to be a Q&A that's live during the session. So just, ask questions. We'll make sure we get your questions answered. So guys, hope you enjoy the presentation. Have a great day.
Thanks, Dr. K. I know you're busy with patients this morning, so it's awesome that you're able to join us for a few minutes. Appreciate the warm introduction. All right, so welcome everybody. Thanks so much for being here with us. I noticed we got a really great roster of interest and some new faces as well, even though I can't formally see you today. So we are going to be talking about advances in sports-related concussion. But before we get started, I just wanted to acknowledge that, why we're here. We wanted to put this program together, being that we are in the middle of March here already. So to all our athletic trainers, happy National Athletic Training Month. I know the theme this year from NATA is providing healthcare everywhere, which you certainly do. And I work alongside many of you, either in the community or in the office day by day. So thank you for all that you do. And also we wanted to celebrate March as Brain Injury Awareness Month. I think the last time we were able to all come together in person actually was about 2 weeks before the pandemic really hit the fan. That was really our last large state concussion summit that we were able to do in person. And my hope is that we can continue to provide these updates to all of you in the community and, have you apply them to your practices and hopefully learn through us and through a lot of our growing pains on what we know that is working or that isn't working. So hopefully next year, maybe we'll get back in person and we'll be able to do this live. So Dr. Kristofiak mentioned our MORAHAN CAARP trademarked approach. And that is our comprehensive academic active recovery plan, which is really like a clinical algorithm that places patients into tracks based on how they present in their symptomatology, and we then prescribe plans from there. So we're going to do a couple review slides on some of the pillars of concussion that we're addressing here at the center for some of you that come to our talks frequently. But we're also going to talk about the things that we're finding and how we're evolving and what kinds of updates we're making in each of those pillars. So before we do that, it's obviously hard to get the audience engaged when I'm looking at a screen, but I wanted to just kind of do a basic inventory. If you guys could help me out. I don't know. I just got a message that it was hard to hear me. Is that better on my staff side there? Can you guys give me a thumbs up? Can you hear me a little better? Okay. All right. So we just wanted to do a little inventory of, you know, clinically, what are we doing practically within the ATR or on the sideline? So if you guys can help me out and just either put a Y or a no, yes or no, very simple instructions. My first question is, are you doing the VOMs on the sideline consistently during your concussion evaluation? Again, are you doing the VOMs consistently on the sideline for your concussion evaluation? So just kind of a simple Y or N. Giving you guys about 30 seconds to respond here. Okay, we're getting a few yeses. Excellent. Cool. A lot of yeses. All right, that is exciting to see. That's exciting to see. I'm getting messages from Mustafa over there too. So yeah, so it looks like a lot more folks are doing VOMs on the sideline than when we asked this question at ATSNJ back in 2019. So I'm excited to see that. And part of today is going to be talking about, all right, there's a lot of tools we learn about, there's a lot of tools we're told about, but what are the ones that are going to be most effective in making that decision when the time comes? So my second question is, are we doing regular symptom check-ins with our athletes after the concussion? Are we doing regular symptom check-ins with our athletes after the concussion? And again, this is during the recovery process. I want to hear from some of our high school athletic trainers too. Okay, cool. I'm getting some yes daily. Okay. It's okay if the answer is no. I know you guys have a lot to do. All right, there we go. I got an honest answer. I try, but they don't show up every day. That I believe. All right, so again, just feeling out your challenges with your athletes. And then the last question is, are you doing any kind of exercise or active recovery with athletes before they become asymptomatic? Okay, got a couple yeses. Okay. Okay, some yeses, some nos. Awesome. Okay, some walking programs. Very cool. Great. Well, some of you are frequent flyers to our program, so I'm really excited to see that you're actually putting it into practice. And certainly use the chat function maybe for the end of the program. If you have any challenges with any of this, those might be great drivers for questions for the audience to hear, for those of you that are really putting this into clinical practice. So I'd really like to hear from all of you as we go along. So let's dive into some of the things you've heard and how we're kind of evolving. First, as Dr. K mentioned, we are going to Amsterdam. So the International Conference on Concussion in Sport is going to be held in 2022. It was held off. It was supposed to be in 2020, but obviously a lot of things were held off in that year. So we were notified that our abstract was accepted for our MORAHAN CAARPTM, and we've been invited to present at that conference. And really what that abstract research showed was that applying that algorithmic approach and kind of putting all those tools together in an organized way was cutting off about 11 and a half days from recovery versus before we had that algorithm and that organized approach in place. So as we continue to learn things about the different pillars that we're assessing in concussion, we are looking to really expand upon that algorithm, tweak it, update it, add some more types of dynamic exercises that are really going to address some of these issues even faster than we are today. So let's go back to just a sports-related concussion and what it is. We all know what it is. I'm not going to bore you to death. But as you really work in, with concussions as frequently as I do, you start to really scrutinize a lot of the definitions out there of this, physiological change as well as, how it presents, right? So NATA, we looked to see if there was a more current position statement and couldn't find anything on concussion specifically. But they're defining sports-related concussion as a brain injury resulting from biomechanical forces producing a complex pathophysiological process that typically results in the rapid onset of short-lived impairment of neurologic function that resolves spontaneously. Berlin has similar language, the Berlin guidelines, so that they kind of highlight impulsive force, again, highlighting the impairment of neurological function, and then also highlighting functional disturbance. Now, the reason why I wanted to bring this up was because, that's me trying to get fancy, but cheesy as well, because neurological function is not something we really can always quantify or measure in brain injury, but it's something that's really routinely studied and still a lot of unknowns on how to qualitatively measure neurological function. But a lot of the testing that we do or we're discussing is more to detect that functional disturbance, right? So how are those symptoms presenting themselves and how are they resolving? What are we doing innovatively and interventionally between the time of diagnosis to recovery to really, improve upon that disturbance, right? So I wanted to kind of make sure you were thinking about that neurological function piece because that's something we don't always talk about. So as I was really mulling over how do we measure neurological function, I asked my best friend Google. I'm sure many of you can relate, and this is what came up. So the three most common and most frequently used measures are functional MRI, MEG, and EEG. EEG being one of the most versatile and cost efficient. So just something to think about again, that those functional changes, clearly we don't have any of these things on a field, right? So as an athlete's being treated, these are things that are being looked at both through cumulative subconcussive blows as well as acute concussion. And we are going to discuss some updates on some of that research as well. So some refreshers on, the leads in a lot of these areas. You hear me talk about Dr. Letty every presentation, and I will continue to do so because he does lead the charge on active recovery. He is a huge mentor for myself and for this program and an invaluable resource. And, he has spent his life really studying exercise intolerance, cerebral blood flow, autonomic dysfunction, and things that are really impacting the brain's ability to recover. So he continues to lead the charge. He's expanded his research into the pediatric population. I saw now that he's working with Children's Hospital of Philadelphia as well as Boston Children's Hospital. And it's coming out with some great parameters even for the little ones. So I'm really looking forward to seeing that. But, he's kind of saying that SRC falls into the 7 to 10 day range for a typical recovery, which we obviously know can easily be delayed for other reasons. And, the most recent research is really pushing on the vestibular ocular motor deficits that often accompany the SRC. And I can say firsthand, that's in more than 60% of our patients here at the center. So it's definitely something we are seeing routinely in our athletes. And for folks that have those deficits, it may take up to 3 to 4 weeks. So, that vestibular ocular issue or those deficiencies, we do see it impact recovery times. Think about, secondary modifiers. I know you do, but, folks that have had a history of migraines or C-spine injury, depression, ADHD, learning disabilities, those secondary factors are definitely going to impact recovery as well, and should be considered. And obviously, the reason why we want to think about this stuff is just so that we can educate the patients when they get frustrated as well, that this is typical. slower exercise tolerance equals slower recovery. And I'm sure for some of you in the beginning that said, hey, I'm using some of this exercise as medicine theory in my own athletes, I'm sure that you see, you know, a Buffalo concussion treadmill test on week 1 versus week 3 or 4, there could be a huge difference in that. But if they do present with higher symptoms early on, that is going to take longer in order for them to get to that asymptomatic point. So cerebral blood flow, we know that there is a loss of control with CBF, right? And so we have to compensate for that, and Dr. Letty did a great job of proving that through his research. And that's where this theory of exercise as medicine really comes about. So for those of you that have not been able to implement this in your athletic training room, you know, some quick reminders, you know, making sure that you're calculating the symptom threshold at 80 to 90% of a heart rate, a target heart rate that you're getting on that BCTT is really going to be what you want to apply to that walking program. And what Dr. Letty's newest research is showing is that compliance is a lot better when the kids have a way to monitor their heart rate. And I realize, like, you know, we can't hand out heart rate monitors, but, you know, if there's a couple in your ATR and you could loan one out, they are pretty affordable as long as you think the kids are going to give them back. Or obviously there's a lot of Fitbit apps and other kinds of things that you can tap into. But, you know, they actually do drive on that heart rate, and they do on their mental health. It's really showing improvement to see that progression. So getting them to kind of work at within the parameters you need them to is showing better outcomes according to his newer research. So we really want to activate the autonomic nervous system early on, and Berlin backed that up in their most previous consensus statement as well. So review on the newest updates from Berlin, which at this point are pretty dated because we are a little delayed on the next conference. But I'm very excited to see what comes out in the consensus statement for Amsterdam, because I think, you know, a lot of the things we're talking about today are probably going to be reinforced in that statement. But a lot of this stuff is probably going to be, you know, repeated in some fashion, and one of that is getting our kids moving after 48 hours. Beyond that, you know, there's really no clinical evidence that rest is needed. You know, using that symptom threshold, focusing on categories for recovery, like we're going to reinforce today. And that definition of PCS, I have to say, that's still just a challenge. I mean, if you really Google post-concussion syndrome and use my friend, Mr. Google, you're going to get like a million hits on different variable timelines. And so the one that I've been seeing most frequently used is 28 days versus a couple years ago when that was more like 21 days. They're now kind of pushing that to 28 days. What I will say is some of our physicians here don't even like to use PCS as a diagnosis unless it's absolutely necessary, because it does really play a role, they feel, in their mental health once they're kind of labeled in that category. So you know, we don't use that diagnosis as loosely as we might have a few years ago. So this is our go-to slide. If you've come to our programs, you've seen it, you've probably you know, kept it or had a photo of it. And we continue to follow this as our guideline for parents, our guidelines for ourselves as clinicians. But we also are evolving each pillar pretty aggressively as we learn about the, you know, the more objective ways we can identify symptomatology and identify progression. So, you know, the cardiovascular and exercise pillar is something we really honed in on over the last few years in our programming, with the understanding that the ocular motor pillar is a huge culprit. And as I said earlier in the presentation, at least over 60% of our patients are really presenting with vestibular or ocular motor deficiencies. And we have talked as a clinical team under Dr. Christofiak's leadership to say, you know, there really should be some earlier intervention with some of these vestibular ocular tasks. And so on top of maybe a walking program, could it be of benefit to do basic hand, head, eye, again, within very strict parameters, easy parameters, nothing crazy, but just to get the eyes moving earlier on. So we'll be kind of reviewing some of those things. The cervical spinal pillar is still a little bit of a muddy water for us. Certainly, we know when the C-spine is a contributor, but dissecting it from the other pillars is not always evident. because the symptoms overlap so drastically in the other pillars. So it's kind of hard to just say this is only a C-spine injury. And then the behavioral cog pillar is still an opportunity for growth. We're all still understanding that, and I think that also ties back into when you get more into that TBI realm or more chronic, concussion situation where you have multiple concussion history and you're kind of ruling out these other pillars and you still see maybe some anxiety or lack of patterns with inducing symptoms that may be more of that behavioral cog driver. So we're really looking at that and how we can expand in that pillar, but we're not quite there at this time. So it's in our toolkit. We're using King Devic, we're using Impact, we're using VOMS, we're using BCTT. But the point I wanted to make with this slide is when you're doing these things in your ATR or you're doing some sideline assessment, your time is limited, right? So we want to share with you, what are we really using for decision making? And I'll send you guys another Q&A. So in looking at the testing we do, as well as obviously academic and active prescription plans, out of the four, what do you think are the two we may most heavily weigh out of these four? You guys could give me a couple guesses here. So out of the four, what do you think are the two we most heavily weigh over here? Any guesses? You guys gonna leave me high and dry? Come on. There we go. Thank you, Aaron. Awesome. Yeah. So treadmill and VOMS, we do put a ton of weight on here. And I see a couple more responses coming in. Yep. And the reason is because, as we know, impact testing, if every one of these pillars is passed and all this testing improves, we're really not going to hold an athlete back for just a positive impact test, right? Because we feel that quantitatively we can really assess symptoms better with some of those other tools. And that's really the same philosophy you should have in your ATR or on a sideline or whatever environment you're in. What I will say, though, is, and I'm sure it's interesting to all of you in the audience, is that impact testing really still hasn't dissolved. It's really still not going away to a degree, and I do understand a baseline versus post comparison, but I'm wondering, are folks thinking about maybe if we don't take it necessarily away, because we do still want a way to globally test kids in large groups, would we ever think about adding something else at baseline? And so, for example, a KD test or something else where we could just get a quick, even a baseline VOR. You may not get a full baseline VOMS because of time, but is there an opportunity to get, things like that that could really help, your evaluation on the sideline? So just again, thinking about all that. So subjective versus objective. We clearly know that this is a thing in brain injury management. Much of what we get is subjective, but if we select the right tools, it's our hope that we're getting close to objectively identifying what we need to in order to recover these kiddos more quickly, right? So this is our, a lot of what most of us are probably using, but we know, like, your head can spin if you look at all the modalities out there, right? So what are the core tests that we're really trying to get in here? And, I really believe these are the ones that stand out. But what I will remind you all of is that none of these will claim to be diagnostic tools for concussion, right? So that's really what we're missing in research is, what's going to give us either a number or something, more cumulative or measurable to say this is a concussion. And that is still, being looked at and unknown in many ways physiologically. So, we have to do our best to make that diagnosis with what we have. But all the research around this stuff is not claiming to be diagnostic. So some of the things we've learned about the pillars that we've reviewed, we know that CVF control is off with our cardiovascular pillar. We know that our autoregulation is disturbed. We know there's autonomic dysfunction in the cardiovascular pillar. We know heart rate variability is affected, and we know that there is a chemical imbalance causing cognitive disturbance when an acute concussion occurs. you have that fight or flight response with the autonomic nervous system, and your heart rate variability with exercise, we know, is going to be just that. It's going to be variable based on intensity of exercise. With a brain injury, this stuff is not happening. It's compromised. And some of the important things to remember in a lot of the new research, since we know exercise works, we're looking at more things of, does variety of the way we're exercising these kids impact recovery times? Right now research is looking at interval training, something I'm really, really interested in. And interval training at like 65% of their heart rate max. I'm not talking about like HIIT training, but I'm talking about, lighter intervals instead of just constant bouts of aerobic activity. So that's being looked at. BFR is being looked at in the rehab setting as well. And so some of these things are very new, and I hope that we learn more about if this can help aid an active recovery program in any way. BFR is more being looked at in the post-concussion syndrome world, but exciting things that are certainly coming to fruition. And just remember the heart rate variability that's really being evaluated. Some of the newer research is studying cool down. And so, if you're not taking vitals in a cool down on a BCTT, you need to, because what some of this newer research is showing is that if that heart rate variability is off and it is not presenting itself during that aerobic phase of the BCTT, that 5-minute cool down response may represent some of that HRV. So they really want you to make sure that you're taking those baseline vitals, blood pressure and heart rate, and then that post-recovery to see and make sure that response is truly what it should be. And so some of that variability has come out in the newer research in the cool down phase. So just keep those kinds of things in mind. So here's a sample active recovery plan that we use. You could certainly use anything you want. I just wanted to let you all know these tools are not just developed for us. We certainly are happy to share tools and have you, use these types of logs. There's no reason to reinvent them. But, our active recovery plan is starting to get more dynamic in terms of what we are prescribing. So this is where we started, just a basic, either walking or jogging, depending on where the patient presents in severity of symptoms. And then you can easily just kind of have them check in with you daily and track how they're progressing, as well as make aggressive changes if needed, if they're improving or getting worse. So all things to consider moving forward. So some updates for us. I kind of already touched on this, but one thing, again, we're really going to be starting to look at is that interval training aspect that I mentioned before. And then in the post-concussion syndrome phase, I'm going to be kind of continuing to look at research with Dr. Krzysztofiak on, is the BFR and the body cooling that they're discussing in the newer research really making a difference? That was more of a pilot study, but I think that the outcomes of the study were really impressive in that not only did the symptomatology improve, but also the mental health of the patient and the behavioral cognitive pillar. And so a lot of the times when the patient gets to that post-concussion syndrome state and they're beyond that 28 days, we can't really identify how much of this is true concussion and how much of this is behaviorally driven. And so I think that it's important to make sure that, we don't rule out that some of these could be anxiety driven, or just like a musculoskeletal injury, if I've re-injured my knee or I've, had a re-injury or an overuse injury, I may be more hesitant to go right back out on the field. I may compromise a little bit competitively because I'm afraid of getting hurt again. All those things are factors for these kids, especially when they get into that PCS zone. But we still aren't exactly able to identify those things as early on as we need to, because we certainly would want to know that earlier on in their treatment plan. So hopefully some of these new interventions can help identify those earlier. So our other pillar that we're really honing in on today is our ocular motor and vestibular pillar. We know the brain is 50% vision. It's amazing that, even 5 5 years ago, not everybody had an ocular motor task or assessment or evaluation that was being done routinely. But now we know we have to do it because we could be sending a kid back in the game that that we do induce symptoms on. And if we don't do it, we could miss something. So now we know it's almost essential. And when I encourage folks to do the VOMs that aren't, I realize if you're already doing a scat, what amount of time that takes on the sideline. So what I would recommend is identify pieces of the VOMs, modify the VOMs to really get some of that essential evaluation in. If it's just a VOR and a saccades, or just a VOR and a smooth pursuit, I would say VOR should be in there, but pick kind of two of the modalities and make sure you get them in. So just so you can be really confident in your evaluation. And we know all these things present themselves and really cause a lot of issues on the academic side, which is another huge part of what we end up evaluating and prescribing here. So what is your recipe for effective diagnosis and evaluation? So in 2021, the American Journal of Sports Medicine looked at predictive accuracy of sports concussion assessment tool individually and in combination. So now that we know, okay, everyone's using this stuff, let's dissect it and see, is one good without the other, right? So they looked at all these things individually. I don't think these results will be surprising to you. This was specifically a collegiate study with 419 student athletes. And they concluded that the best really lacked clinical significance determining concussion on its own. That wasn't extremely surprising to me, and I think the reason for that is that back when I started in 2011, we were doing an immense amount of baseline balance testing, and kids' balance was, it was pretty awful. The gymnasts, the figure skaters, the ice skaters, their balance was fantastic, but even at baseline, their balance was not great. So, and we know best is subjective in nature when we're determining errors and things. So it's kind of controversial. I still think it's necessary, but of course it can't be in a silo by itself. When we looked at VOMs combined with SCAT, just together, it produced a 9% improvement rate in test sensitivity. And I think that's a really good take home to say, look, if I have to pick what I'm going to do, let's do the things that are going to work most effectively in my evaluation and give me the most information. This study estimated that an additional 304,000 athletes could be diagnosed annually with this combination of testing. But I think that's just to make the point that, choose the ones that are going to give you the most bang for your buck. So how do we evolve, right? We want to identify the driver that presents recovery delays and progress early. So we're really interested in the center in getting earlier and earlier on identifying the interventions that work, right? So when we first learned active recovery, we conservatively started it to see how our patients responded. As we became more comfortable, we got more aggressive, and now obviously we're very comfortable in the patient outcomes. We know we're not harming the patient, and all that the research supports that. So now we're very interested in, well, what else are we missing? What else could we be doing that will really speed up the recovery even more? And some of the MCAARP data that I discussed in the beginning was relative to the initial evaluation to the discharge date. I had said we cut off about 11 and a half days, but what I didn't mention was that our rehab interventions were also less needed. We didn't have to send as many kiddos to rehab because they were getting better sooner. And so that's kind of always our MO, is like, how can we continue to evolve in that way? This particular study was from the Clinical Journal of Sports Medicine in 2017. It looked at vision and vestibular system dysfunction during prolonged concussion recovery in children. It was 432 subjects, 378 presented with visual vestibular dysfunction, which is over 87%. Again, reinforcing the reason for doing some of these VOMs elements on the sideline. Presentation consistently identified with some balance issues with accommodation and symptom provocation with VOR and smooth pursuit. That just gives you some more ideas for if you have to choose a modified VOMs, what are the tests that I should be implementing. And the above findings were associated with prolonged concussion recovery. So it goes back to that ocular motor pillar really being a culprit. this is your standard VOMS that includes all the different assessments that you could do. That's what we're doing in the clinical setting. Obviously, we have more time than you on most occasions, so you know you could tackle a couple of these and make it just as effective for your use on the sideline, because your use is really evaluate and decision make, right? But some kind of cool facts. What I would want to just reinforce is download a metronome app and do it right. If you're going to do a VOR, make sure that the pace of that head is correct. You want to get it up to 180 on the metronome app and make sure that they're moving fast enough. Just to give you an idea, if you double that metronome pace of what we do of VOMS to over 300, that's really what a high performance, high level sport is in terms of head speed. And so if you're inducing symptoms at half of that speed, it's going to make you very clinically confident that something is off. In our world, 30 reps of VOR equals about 5 minutes of reading. So we're doing 10 reps in a VOMS. And with those 10 reps, if we can't get through that, or we can't do a simple KD test, it gives us a good indication of academically where we should be with these kids once they leave our center. Those kinds of things can also help as you progress academic plans. You're all familiar probably at this point with KD. I'm not sure you all have access to it, but it's very, very helpful. A new study that Dr. K actually forwarded to me from the British Journal just came out in 2021, looked at a bunch of different sideline tools, and KD actually led the charge on most specificity with accuracy in order to differentiate that concussion diagnosis. So, you know, KD is a really good tool. I mean, it helps for a lot of things. It's quick, it's easy. It really only takes a normal KD, you're looking at, 25, 30 seconds for an advanced athlete versus somebody who's compromised that may be over, a minute in some cases. But it's telling us a lot about saccades. It's telling us a lot about, auditory processing, because they have to speak the numbers as they read them. And then it's also helping us, again, with academics and prescribing a plan. But what I would say is, as you think about these things, one thing that we learned as well is that, get them in the right hands quickly and evaluate it, but also don't rule out the fact that this could be an unspecified head injury and not necessarily a concussion. So we have at the MORAHAN Center been able to create an unspecified head injury track, which gives kids some breathing room from being labeled so quickly with the concussion. As I'm sure many of you would agree that if you've all been in the field, probably some of you longer than me, 10 years ago, 9 years ago, there was a lot of concussion diagnoses, like right out of the gate. I mean, an immense amount. And there were kids coming to the center, and we were all kind of looking at each other like, I don't know if this is a concussion, but what do we do with them? Because obviously the liability and the concern of how do we rule out concussion, more objectively, and what's our comfort level had to be determined. So here we have what's called an unspecified head injury track, where if kiddos are, not experiencing symptoms beyond 48 hours of that initial contact, we still work them up as if they could have a concussion. But if they pass all our physical testing and they pass all our ocular motor testing and our balance testing and everything else, within that same day, our physicians feel confident, this is not a concussion. And if you can do a couple burpees, some jumping jacks, and, some head turns and some hand-head-eye today with our athletic trainer, we're comfortable clearing you for contact without a return to play. So as you can imagine, that's a really good out for kids that you're on the fence about. And you really want to use resources like that within your communities, because it's imperative that we don't over-label these kids with concussion. So we've really, stressed the importance of the sideline stuff. That is my VOMS athletic training team in the universe there. I just thought it was a great photo and looks intense, as most of you are on the sideline. But really, we want to know, is VOMS part of your universe? And if it's not, we want to convince you to start making it part of what you're doing on the sideline. And then just reinforcing the return to learn before return to play. So I'm going to pull the group again. Are you consistently seeing confirmation of academic restrictions being lifted before an athlete starts return to play? Again, are you consistently seeing academic restrictions have been lifted in the classroom before a student starts a return to play program? So by that I mean they've at least had 1 to 2 days in the classroom off academic restriction. Okay. Someone new that hasn't responded. Oh, there's one. Okay, some no's. Okay, that's kind of what I thought. So we have some yeses, some no's. So as an athletic trainer, and again, I know everyone's relationships with their nurses are different. We would really want to encourage really solid communication with the nurse on that academic plan so that you know what's going on in that classroom. Because if you get that note that this kiddo is cleared for return to play, they need to be in the classroom, minimally a day off restriction. And what we found with a lot of our colleagues in the area or just working with pediatricians and educating some of the folks we work with, they don't always remember to remove those accommodations before issuing a clearance. This is at the international level. This is on the consensus statement. Return to learn before return to play. Somebody's got to hold the accountability of that happening. And if it's the nurse, that's great. I just think that maybe re-education on that academic return might be necessary in some communities. And we've been asked to come in and do some academic programs for that reason. So if that's a challenge in your area, please let us know. And then just, make sure in your return to plays and things that you're thinking about dual tasking, you're having them do some memory recall, some color recall, whether you're using colored cones or doing some drills, but that's kind of all part of that return, as well as their ability to be in a classroom. And, this is how we're having folks tell us what they're doing in the classroom, but we're even moving to an electronic method that's a lot easier for us. We haven't gotten there yet, but we have it all prepped because it is hard to hold kids accountable. It is hard to get them into your ATR and hand you something to tell you how they're doing, but their incentive should be that we can get them back out on the field quicker. So the more they can report to us that there's a change, and maybe that's the language, like, yes, a symptom check-in daily would be ideal, but minimally a weekly check-in so that we can see they're improving or they're not. And aggressive changes can be made to their plan of care. I think that's where we really lose kiddos in this process. And even at the center, I know my staff does a really good job of hounding parents, but, again, that accountability on the timeline of being able to get them back faster needs to be really enforced. So some things that we're looking at in the ocular motor pillar and some new things are VO tasks. So basic hand, head, eye movement, basic things like just simply throwing a tennis ball up from one hand to the next, following it with your eyes and with your head, right? Looking at basic programming that, yes, you're still going to do your walking program, but I'd also like you to do 2 sets of 10 of maybe active neck range of motion or some basic vestibular hand, head, eye, ocular tasks. And this is not to confuse people. This is not to complicate this with parents, because obviously parents can be overwhelmed. We actually separate our visits on 2 days. We do the initial visit and we kind of focus on academics, and then on the follow-up visit, which is about 2 days later, we'll do an active day to talk about, okay, this is what we want you to do as your active program, because it can be a lot to digest and understand. So our team is now going to start integrating a VO program that builds in ocular motor tasks such as this. We're also looking at VOR, so building in almost like a metronome pace for VOR reps with our patients on a daily basis. And we're going to study that and see if it truly improves recovery timelines when it's complemented by the active recovery, walking or jogging program. So we will have more information on the outcomes of that, hopefully within the next 4 to 6 months. But we anticipate, just in what we've seen in the evolution of the treatment that we've been doing, that there will be a significant improvement in recovery. Again, if the patient is compliant, right? So that's always the challenge, is how do we track that? in an athletic training room, it would be our hope that as we learn and we can teach you, and you'd be able to do some basic tasks, again, not having to watch them throw a tennis ball from hand to hand, but being able to sit, off to the side and do some activities while you work on another athlete would be a really nice evolution of this program. We're also looking at convergence exercises. We have some colleagues in the field that have been really looking at this closely. Some recommending some single-eyed reading, that there's always a weaker eye with concussion. So we're kind of looking at some convergence things, and as we're learning, we don't really see harm to the patient in doing some of these things within strict parameters, and giving, again, strict guidelines, so not overdoing, right? So we're going to start, just like we started active recovery, we're going to start conservatively, and we're going to kind of underdo and see how the progression of symptoms is affected. And then again, just talking about single eye strengthening throughout the recovery process. So what do we know today? We know exercise is medicine. We know active recovery works. We know rest is not best. We know recovery plans must be prescriptive and also progressed, right? So sometimes we get caught up in that initial week of the kiddo's active recovery, and we may not evolve the active recovery plan. So just knowing how to evolve, how to be aggressive in that way, I think is important. Symptom severity can be a prognostic indicator for recovery. We know early diagnosis, intervention, and treatment drive improved patient outcomes. We know about multiple concussion histories, and we know mental health effects and behavioral cognitive factors exist. We don't necessarily know how to always measure them to benefit our plan of care. So that's still something we're looking into. So, this is a sample, just AT rehab program that you could use for a musculoskeletal injury. And I put it up because I thought, are we doing things like this during a concussion? Are we having that active recovery progression? Are we logging everything and making sure we're doing it much in the same as we would with a musculoskeletal injury? Are we doing a BCTT every 3 to 5 days? To see, their symptom threshold's improving. Let's add, a little more time on a walking program, or maybe we'll try a bout of jogging, depending on how they're doing in school with their vestibular ocular issues. All those things, could be really great intervention that you all could have access to more regularly than even a concussion center. So we're really looking for support to be able to work with all of you on being more aggressive and doing these interventions. And then thinking about VOR and hand-head-eye, not necessarily to implement it today, but just thinking about possibly in the future, a simple task that could get, the head, hands, and eye all kind of working together. And again, I'll keep reinforcing the word simple. So we're not trying to make this complicated out of the gate. And then the last thing I'm just going to reinforce on the pillar end is the return to play. And making sure that a heart rate monitor is really being used, or you have at least one heart rate watch on your equipment list for the 2022-2023 school year, just to build in those metrics. And like I said, Dr. Letty is now even studying that we're seeing better outcomes with prescription with heart rate monitors and getting true heart rates on these kids with intensity. So how do we measure? We're talking about measuring. We're talking about objective versus subjective. Objective measuring needs to be encouraged, and it really should be documented so that you're really hitting these milestones. You're confident you're hitting them, and we can progress the kid to full contact. So how many of you in the audience at least have a heart rate monitor on your equipment list or in your ATR today? Just give me a yes or no. Okay, so a lot of no's, couple yeses. So we can, you can add that to your next inventory. It'll cost you anywhere from maybe $80 to $90 at this point. And you can get extra heart rate straps if you need, but you probably won't need many unless you have really teeny athletes. And then also, thanks, Matt. So Matt just said Apple Watches obviously work in a pinch also. So, I would really encourage you to think about that and reaching these heart rate reserves to make sure that you truly are mimicking that dynamic, practice and competitive environment. So let's talk about like some evolution of where we're going with concussion. So objective vision advances. This is a really cool tool that I just wanted to touch on for the center. I realize that athletic trainers aren't going to have access to necessarily an eye sync in their clinical practice. It's very expensive. It's at the professional level right now. But this is the direction we're going in the clinical setting. And so this is a really cool tool. It takes 60 seconds and it captures everything in a VOMS. It captures, it has the standardized inventories for your SCAT, your VES. It has your simple reaction time. It even does a PHQ-9 for that behavioral cognitive pillar for some depression screening questions. And then on top of it, you're getting all your vestibular ocular data and ocular motor data within that 1 minute time frame. So what does this do? I'm sure you guys are like, wow, this is cool, right? It takes away the subjective nature of what we're doing and it makes it more objective. And when you're in a clinical center like ours who's seeing 300 plus concussions a year, this becomes extremely practical for us in terms of what we can do for our patients. And it also has a cloud-based function that allows us to prescribe, some homework for athletes to do even on a computer in order to strengthen the eyes and or improve on some of the VOR. The cool thing about it is it's one of the only tools that I can find that is claiming to have diagnostic capabilities. And that's a huge deal for us in concussion. We were all probably saying, finally, I can't see your faces, but, we don't have anything that's just saying, yes, this is a diagnostic tool. Much of the apps and the neurocog testing, the things that we have, no one's going to make that claim, but iSync is making that claim, and they have the evidence to support it. They've been studying this for over 15 years. They have over 40 publications. It's just truly impressive. Our center is actually getting in-service on it next month. I can't tell you how excited we are to have this in our hands. I just think it's going to truly, truly evolve what we're doing in the ocular motor pillar and again, improve recovery timelines, because what have we been saying since the beginning of this presentation? What are we doing objectively to identify early diagnosis? We have to work within, our resources, right? But if we have centers and other clinical folks that can evolve it and get equipment like this to support those early identification of symptoms, I just feel like we're going to see kids getting back out there a lot quicker. How many of you have seen the movie Concussion? I'm going to poll the audience again. Yes or no, you have seen the movie Concussion? Okay. All right, we got like a 50-50 split here. I would love to see your faces or ask you what your clinical opinion of concussion was. But we all know that based on a true story comes with some open-ended variability of actual factual information. I think concussion really started to get CTE out in the world, and although a lot of the detail was fabricated, as most of this stuff is, it got people knowing it exists, right? And so, as we talk about acute brain injury management, we don't often talk about subconcussive blows, but I think it's important to talk about today because a lot of the research you're going to see on, evolution of where concussion and brain injury medicine is going is going to link back to, really understanding something besides that functional disturbance that we talked about on that first slide, right? So advances and considerations in brain injury management. What are we really looking at in research outside of that acute brain injury? We're looking at the subconcussive blows and neurological impairment that lasts beyond the symptoms resolving. And probably scary to think about for all of us, but we need to think about the fact that it exists. Brain activity pre and post concussion is something that's being looked at, which is really, really interesting, and I'll share some results of that. blood biomarker trends, it's been something that's been studied forever. And I'm not sure we're getting anywhere with that, although yes, we see changes, but we don't know necessarily what to do with them. Objective and validated visual assessments, as you just saw one that I shared with you on the previous slide. Retraining autonomic dysfunction and VO impairment with more variability is something we also shared with you today, and enhanced diagnostic capabilities. So all the research kind of going in that direction is trying to reach the goals on this list, okay? So now the question becomes, how do we differentiate between symptom resolution and neurological impairment? Does anyone know the answer to that question in concussion and brain injury medicine? No. We don't know how to differentiate that completely and diagnostically, so we're using the tools that we have, but we hope to evolve and get to that point. So that picture is me when I was trying to look at all the electronic devices, modalities, apps, everything that is out there for concussion, and I assume some of you feel the same way. There's just so much out there, and like a lot of times our center will get approached on, you know, hey, put this on your kids and let us know if it works, or you know, try this app and tell us what you think. And you know, what I really see is you have 10 apps when you could really get the same results in one test, right? So time is valuable to everyone in this WebEx. And so we really need to consider, we have limited time, what's going to tell us the most. And so you could put 5 of these apps together and probably get the same results of doing a VOMS and a KD together. But that's really the issue I have with it is, you know, nothing really stands out. So this particular article was done just this past year. It was a technology and concussion study, and it was really a review. So they reviewed 29 publications, common themes for visual, motor, neurocognitive balance, dual tasking, all up our alley and in our life. And basically the conclusions are we need more accurate, validated technology. So some things had high specificity within an app or within, you know, a technological platform, while other modalities didn't. And in the practical clinical world, that doesn't really help us if half your app works and half doesn't, right? Technology was helpful in identifying symptoms. So if there is an electronic way to get, you know, the ability to track symptoms, I think that we're all moving towards that, and we would appreciate that because it's just easier for everybody, with the understanding that you're responsible for what's being reported. So that was the point they made. If you're going to collect the data, you got to monitor it, right? And do we really have time for that? Here at the center, we do, and so we are moving towards more of an electronic method for symptom monitoring. Across the board, neurocognitive testing had questionable sensitivity specificity, and those are the platforms specifically that we are familiar with, like the Impact, the C3 Logix, the Headbinder. Those are the things they looked at. So I don't think that's overly surprising to many of us in the audience, but you know, as we know, I don't think any of us would think it's quite the best tool in the toolkit, right? And then iPad visualization testing offered little evidence on differentiation for concussion. We don't know, they didn't specify what iPad testing they were using, so that wasn't really as helpful. But as I mentioned in a previous study, KD was really heavily validated in 2021 as a good sideline tool. All right, so let's dive into like the subconcussive blow. So we talked about technology, we talked about pillars, we talked about evolving those pillars and thinking a little bit more creatively on earlier intervention with these kids and aggressive monitoring to make changes more quickly. So now we're talking about things that we really have no control over, we don't have enough evidence to really understand, but we still want to be aware of, right? So what are the challenges with subconcussive blows? Chronic impairment affects difficulty quantifying the relevance of the change. So all this research, it's been evolving for the last 10 years plus. We're seeing changes. We know there's changes, but we can't quantify the change, how long that change has been there, and what really we're supposed to do with it in terms of the course of changing our treatment. So I think hopefully in another 10 years, if we're all still evaluating concussion, we'll have more updates for you. But the issues are longitudinal studies and funding. A lot of the stuff that we need to do these studies is costly. And you have limited population studies like willing to do them. So we don't have a lot of youth athlete studies on this stuff. It's more like those professional athletes, folks that are really more curious about the CTE and what the effects are. And it's very contact sport heavy. So it's not like we have a lot of studies looking at across the spectrum of all sports and ages. And so that it becomes very challenging to implement any kind of practical application in the clinical office if you don't have that wide scope of data. Functional MRI it has been studied for a very long time, and it is showing significant changes, but it is extremely costly. It is time consuming, and it's often not covered by insurance. So in order to get the data sets to really prove this is something of worth, it's going to be challenging. The functional outcomes, duration, and consequences of imaging changes related to subconcussive head impacts are not well understood. And so I think that's really important to make that point, as well as that we don't fully understand what's going on, but we do know that they exist. So how do we advance? How does this help us? We really need we need to study varying populations, and we need to do more studies that really get us more dynamic data. And we need to quantify these impairments so that they can be, really used in the clinical setting and practically, so that we know, the question everyone wants to know and no one can answer is, should I think about medical retirement? It's an opinion-based question, no matter who you are, no matter what sport you've played your whole life. No matter what stage you are in your career athletically, that is going to be an opinion response. It would be amazing to back that up with some of this data that's being studied, but we're just not there yet. This is a study that came out in 2019 and I thought was really, really cool. And I believe this could be some breakthrough, technology that exists and is cost effective and that could really help us in brain injury evaluation. So this particular study looked at brain vital signs that detected concussion-related psychological impairments in ice hockey. So it was specifically the sport of ice hockey. 47 junior ice hockey players, 43 of which completed a baseline EEG. So that's really helpful because we have like a pre and post. Some with previous concussion and some without. So a little bit of some modifiers there. And then ages 16 to 18 was, very small age range. But the conclusion was that neuropsychological impairments persisted after observable clinical signs and symptoms subsided. So I think, how do we feel about that? Well, I think how I feel is that I'd be interested to learn more about EEGs. EEGs are safe. They're affordable. They're much more often covered by insurance than a functional MRI. And so, this particular study showed impairment in EEG studies, both with brain vitals and amplitudes after symptom resolution. Knowing that there's nothing to objectively measure subconcussive impairment, this is of a huge interest to me. And I don't know if this is something practically we can look at in a clinical model and study, but I think it may be worth it to think about for folks, even like us that have such a huge patient population, because it could really help us understand if the symptoms resolve, if that chemical imbalance within the brain is really fully restored. And I think all of us on this call or on this this WebEx would want to know that. So, in conclusion, just some points I wanted to make about what you've heard today. Don't rule out that behavioral cognitive pillar. Your kids, your athletes. If their symptoms resolve, think about the fact that in a month, if they're not themselves, if they're having erratic behavior, if they're way more irritable, if mom and dad notice things at home, don't rule out the fact that that may not be related to a multiple concussion history or those subconcussive events that we really can't measure. And again, you can't really prove that, but you can encourage that athlete to get, some further evaluation, or get some, maybe some sports psych involvement or something to kind of just look at that correlation and make sure there's nothing that could be detrimental to what they're doing, on the field. Considerations of neuropsychological impairment can exist beyond symptom resolve, as we just kind of addressed again. Quantifying the effects of cumulative functional damage over time from subconcussive blows is still not well understood, but we're hoping for advances in technology to help us better understand those issues. And then the advanced imaging, we know, still has limitations. So as, frontline clinicians, what can we do? We can stay ahead of what's out there and, try some basic VO tasks that are very easy to prescribe, as simple as what I described with the tennis ball. And just observe the athlete, see how they're doing with 2 sets of 10 of those reps. In addition to a walking program, maybe you notice that this is going to accelerate some of their recovery within the classroom. If it in any way makes them worse, you can scale back. But, don't be afraid to kind of dabble in some of these things and address them, because we know earlier intervention is going to help. And we don't want to just ignore the eyes for 3 or 4 weeks until we realize this kid's reached the plateau, and then now they need true rehabilitation. If we can get to them a little sooner with some of these interventions, I think our outcomes are going to be a lot better. Think about your athletic training room. Think about how you manage all those athletes, and the same way you would do a functional assessment, to return a kiddo after a musculoskeletal injury, try to think about doing a Buffalo concussion treadmill test for a kid with symptoms. How are you progressing that treatment plan? How are you progressing those interventions? How are you monitoring those interventions? Whether it's through some of these electronic formats that we described, or whether it's just weekly or daily check-ins, whatever your capacity is, we want you involved between the point of diagnosis to the recovery, because centers like ours, that open communication line, I really think will make a difference in them bouncing back. There's so many times that the athlete is not telling us, hey, my symptoms are cut in half since I last saw you last week, and we have to call them and hunt them down, tell us those things. Well, we could have started a different regimen or pulled them out, put them in full days of school and got that clock starting towards a return to play progression had we known, those big changes were happening. So that athletic training check-in and that communication back to us could just be the bridge that we need to get them back to you quicker. Choose the right tools that are practical and effective for your evaluation and management. So if you have your hair, you're pulling out your hair like I was when I was reading all the resources that are out there, choose the ones that make sense for you, choose the ones that give you the most for your time. And then track and progress and keep communication lines open as I described, so that we can all work together as a multidisciplinary team for more aggressive outcomes and interventions. And now I'd like to open the floor for questions. I appreciate for those of you that were engaged in answering some of my Q&A, as well as your attention today. So, Jess, I see that you're still with us there. Not sure if your mic's working, but
can you hear me?
Yes.
Yes. All right. Yeah, I will keep an eye out. I don't see any questions right now. Thanks for everybody for joining. That was a great, synopsis and a way to get us updated and kind of continue to move forward to treat our patients in the best ability. So it's been a great update. Let's see. I do see one question here. So student athletes who are in an unstable position or on an unstable surface during their play because of their movements or the surface they play on, has there been any talks of completing research? Oops, I lost it, sorry. Completing any research on performing bombs on a blue foam pad, single leg, or other unstable surface, much like the BESS?
No, in terms of so is it specific to a sideline assessment we're thinking?
It didn't specifically say, but I would assume at some point some kind of assessment, whether it was sideline or just in the athletic training room.
No, I think the natural, I know for some of our post-concussion syndrome patients, like our therapists do engage in some of those multi kind of pillar approaches to make sure they're engaging both the vestibular system and the ocular motor, and using those unstable and stable surfaces in the acute clinical setting. We haven't discussed it. It's a great point. And as I said, as we evolve into this VO task library and really see how effective things are, I can really see our team getting more creative with what we're prescribing and also what we're observing. But we have to kind of build confidence in that first 1 to 2 weeks to make sure we're not overdoing it. However, I do know that it is used in the rehab setting, but we haven't looked at, if it's effective or not in research.
Right. Okay, great. So then the next question was, what are our thoughts on sway versus impact? And I know we actually just tested out the app ourselves. And, we haven't sat down clinically as a team yet to kind of go over our thoughts. But that was the next question.
Great question. So, you know what? You guys have a lot of the same questions I do. So, you know what, to Jess's point, it is in discussion right now as to if we're going to utilize sway. I think we're going to probably trial out sway on a very small scale to see how we're going to integrate it. Because we have a large baseline population as well as a post-concussive population, we're kind of trying to see, does sway in some way replace what we do in an impact world, or doesn't it? Are we still capturing as much data as we need? I know specifically our medical team liked that the best was more objective, but we're still looking at the research tied to it. I think it does give you more bang for your buck in terms of a quicker assessment and symptomatology. But one of the things I will say is I reached out to the sway folks, and if you have played with sway, the best is like a lot. It's like 3 or 4 reps of the same best. And so one of our first questions as a clinical team was, can we modify the platform because we don't need to do this much best? And the answer was yes. So as we decide how we would modify it, I think it could be potentially a practical transition, but we're still looking at it.
Okay, great. Another question was, how long should athletes be asymptomatic before starting the return to play progression for sports?
So ours is age-based here, our protocol, and we're evolving even with pediatrics as we speak. We haven't launched it yet. So, we have consistently been doing high school athletes after 48 hours of complete academia. So that means off restriction. By the end of that second academic day, we are clearing for a return to play progression. Whereas many years ago, we were waiting a full 7 days for the athlete to be asymptomatic. We are no longer doing that, nor do we feel it's necessary. For the younger kiddos that don't have an athletic trainer, right now we are even talking about doing, again, a possible RTP progression, always in a clinically supervised setting for the 10 to 13-year-olds, still after that 2-day academic window, but we haven't launched that yet. So I don't have any feedback on how it's going. But I would say at the high school level, we have not seen any cause for concern.
Okay, great. It does look like they're asking for some of our resources and slides, which we do post when we send out our link to complete the CEU. So those of you are asking for this information, yes, we will send that out to you. As far as emailing some of our assessment forms, I think some of the information will be on those slides. You can probably use as a guide to create your own. I understand sometimes it's harder when you have some of these bigger school districts or they're not quite so geographically close and friendly. It's nice to have some of these resources at your fingertips. So I think a lot of this information will be helpful. Once you get the slides to you, you can kind of pull from them. And certainly anybody can reach out to us if there's any follow-up questions, or as you're trying to update your policies and procedures with your concussion protocols at your schools, having those conversations with your school and team physicians to advocate for your patients, but certainly as far as what we as athletic trainers are more than capable of doing and handling under the supervision of our physicians.
Yeah, and if there's anyone that wants a PDF of the tool for their own use, you can email us directly, and we're happy to, share those tools.
Yep. Looks like that's it on the questions, unless I missed some. Don't think so.
Okay, awesome. So, keep an eye out within the next month or so. Well, we're gonna be, actually, Jess, do you want to talk about the next, CEU event that we have
Yeah.
upcoming?
Absolutely. Thank you. So in April, on the 6th, we are going to be doing an update on COVID. I know everybody's super excited to be talking about that still. But we just felt it was a great time to kind of circle back on, what was happening this time last year, and what's happening now. We'll be having Dr. Lander, one of our sports cardiologists, give us an update, Dr. Kristofiak as well. A lot of you may have made some changes to your requirements for a return to play protocol as far as anybody who is a COVID diagnosis. And we just wanted to check in with everybody and see how they're doing. So that's going to be a virtual event on April 6th. Most likely it's going to be in the morning. So it is going to be in co-sponsorship with ATS&J for our regional representatives. The nice part about virtual is it does allow us all to come together. So that's a great opportunity, and having a great panel of my colleagues here at RWJ. So you'll be getting that information out very soon. We're just finalizing the flyer, so keep that in mind for that first week of April, and then an attendance will come through for you guys on that. So it's going to be a good topic, I think, timely in this particular scenario with everything going on.
Yeah, but keep a lookout for an email for, the CEU, evaluation, so that we can issue your credit, which Jess has so kindly offered to offer, some help with, so.
Great.
We'll try to get those out to you as well, very soon. We want to thank you for, all your attention today. I see a lot of folks joined us, and hopefully we will have a lot of more updates for you to share as we put a lot of these things into action here at the center. And we'll keep you abreast of any upcoming programs.
Great. Thanks, Diana, for sharing your knowledge. As always, it's extremely helpful for us in our clinical setting. So thank you for hosting again.
My pleasure. Thank you, everyone. Take care.
Bye.